Good morning.
Morning.
Good morning. Yeah, I'm very glad to have the Zoom session because the Jejuma, whatever system, it keeps crashing. So,
Oh dear. Oh no.
oh my God, I was in this session for students on Wednesday. 5 times I had to go reboot.
Oh no.
Yeah,
That's
so I'm
so
really happy we have our own Zoom
stressful.
link.
Yeah. Yes. Zoom. I know. Zoom.
Yeah, me too.
Zoom. I generally trust.
Yeah,
There's always still something, right? Like
right.
there's always something, but
So stressed
crashing
out
at
by
a
that.
time it's hard
So,
to recover from.
Alyson, were you able to change that slide?
I was. Yeah.
Okay, thank you. I just like to know.
Helpful to us.
And since this is a workshop, if you're willing and able, we would love for folks to come on video so we can see your faces and make this feel a bit more engaging for all of us. So if you're in a place where you are willing to do that, please feel free to turn on your videos as well.
All right, well, we're at 8:32 Central Time, so we'll go ahead and get started so that we don't waste another minute of content. Thank you everyone for joining this Friday morning. My name is Lynn. I'm one of the City Match staff members, and I'm delighted to have this workshop for you here today. We have a panel of wonderful public health professionals who will talk about extending postpartum Medicaid coverage for us today. And I do believe that they have a couple of requests for entering some information about yourself in the chat so that we can all get to know each other. And if you are comfortable with it, please have your camera on because this is a Zoom meeting, not Zoom webinar, so you can interact with each other, have some discussion, some conversation. And Angie, I'll pass it to you to get us started.
Great. Well, welcome everyone. And thanks for coming today. You guys we're going to be talking about extending postpartum Medicaid coverage, why it matters, and how stakeholders are pursuing this foundational policy approach. And my name's Angie Snyder. I work at the Georgia Health Policy Center, which is part of the Andrew Young School at Georgia State University. I am the Director of Health Policy and Financing, and I also work with UNC Chapel Hill for their maternal health innovation program. And several of my colleagues are here today, plus some other wonderful guests that I have met along the way. And I'm going to introduce them to you, and they'll be introduced in the order that they're going to present. After I introduce them, I'll go a little bit through the agenda today, so you all have a sense of how this day is going to go. So first, Dr. Jamila Taylor. She's Director of Healthcare Reform and Senior Fellow at the Century Foundation, where she leads their work to build on the Affordable Care Act and develop the next generation of health reform to achieve high quality, affordable, and universal coverage in America. Dr. Taylor also serves on the board of directors for Black Mamas Matter Alliance, March for Moms, and Mama Toto Village, where she serves as the chairwoman of the board. And second, we have Alyson Northrup. She's the Associate Director for Public Policy and Government Affairs at the Association of Maternal and Child Health Programs, known as AMCHIP. In this role, she executes AMCHIP's policy activities, including advocating for the Title V Maternal and Child Health Services block grant funding, promoting AMCHIP's federal policy agenda, and representing AMCHIP in various policy coalitions. Alyson also serves with me as the Policy Core co-lead for the Maternal Health Learning and Innovation Center at UNC Chapel Hill. And then third, we have Dr. Arden Handler. She's the Director of the Center of Excellence in Maternal and Child Health and Professor in the Community Health Sciences Division of the University of Illinois at Chicago School of Public Health. She is one of 3 of the PIs for I Promote Illinois, a HRSA-funded state maternal health innovation program focused on reducing maternal health inequities in Illinois, using a variety of approaches, including innovation, implementation, and policy change. And then finally, we have my colleague Sashoy Patterson. She's a research associate at the Health Policy Center with me. She performs research and evaluation for maternal and child health policy issues, including telehealth and postpartum coverage and care. And Sashoy is also a member of the policy core of the MHLIC. So, all right, Alyson, those are our great presenters today. And here's our agenda. So first, Dr. Taylor will start and she'll set the stage for maternal child, the state of Medicaid and health equity in the United States. Then Alyson will talk about the policy lay of the land. We'll have a short group activity, and then we'll have our two state folks talk about what's going on in postpartum extension in Illinois and Georgia. I have some questions as the moderator, so we'll have a moderated discussion first, and then we will open it up for you all to have Q&A. So I would ask, we can make this fairly informal, but if you have questions of clarification for any of the presenters, or you think of a question along the way, we will have a little bit of time at the end of each presenter to ask clarification questions. You can put those in the chat, or you can hold them until the end of their presentation. And then if you want to hold like overarching questions till the very end, that works as well, or throw them in the chat and I'll just say, I'm going to try to moderate this. I'll just say, oh, let's hold that one till the end, because I think there'll be more information shared. Okay, great. Well, without further ado, I will turn it over to Jamila to talk about, to set the stage for us.
Good morning, everyone. Again, I'm Dr. Jamila Taylor, Director of Healthcare Reform and Senior Fellow with the Century Foundation. So the United States is in the midst of a maternal health crisis that falls hardest on Black women and their families. Next slide. So here we wanted to give you a taste of what we're seeing when it comes to racial disparities in maternal mortality. Black women are about 3 times more likely to die of pregnancy-related causes when compared to white women. For American Indian and Alaska Native women, they're about 2 times more likely to die. Next slide. The root cause of these racial disparities is racism. According to the Aspen Institute, structural racism is a system where public policies, institutional practices, and cultural representations work to reinforce and perpetuate racial inequity. Next slide. So how does structural racism manifest in care? It does in several ways. And what I'm presenting here is not, sort of an extensive list, but these are just a few I wanted to lift up, particularly as they relate to the context of maternity care. We see structural racism manifest in the fact that health provider shortages and lower quality hospitals tend to be concentrated in neighborhoods where the majority of people of color live. We also see it in racial bias and stereotyping of people of color by healthcare providers. We see it in differential treatment practices and management of pain. We see it in a lack of culturally responsive care. And we also see it in efforts to undermine or sabotage publicly funded health programs such as Medicaid, which we're going to talk about at length today. Next slide. So racism drives maternal health outcomes, and this has been proven by an extensive body of research. Research suggests that the cumulative stress of racism as well as gender oppression undermines the health of women of color. Racism is fueled by predominantly white power structures that perpetuate power imbalances, and we see this in the relationships between physicians and their patients, and a lack of empathy and respect for people of color. This means that any solutions that we develop to address these issues must be grounded in social justice frameworks that are intentionally designed to address these power imbalances. Next slide. So this brings us to the reproductive justice framework. This is a framework that was coined by a group of Black women in the mid-1990s at the International Conference on Population and Development. It is a human rights-based structured approach that addresses the intersecting systems of oppression that prevent marginalized people, primarily women of color, from achieving complete bodily autonomy and parenting with dignity. Next slide. So when we take into account the reproductive justice framework in developing solutions, it means that we recognize a woman's ability to determine her own reproductive destiny. We recognize reproductive freedom as linked to the conditions within a birthing person's community. We center women and birthing people of color and their unique experiences in our solutions. And we recognize that health outcomes and access to healthcare are central factors that cannot be divorced from social issues such as economic opportunity, exposure to violence, and safe, affordable housing. Next slide. So as we get into the conversation about Medicaid, I wanted to just offer a review of some of the patterns that we see when it comes to Black women and healthcare in the context of maternal health. The first is that Black women are most likely to die of pregnancy-related causes, which I talked about a bit earlier. They're most likely to also experience serious illness and injury due to pregnancy-related outcomes. And we know that they make up a disproportionate share of Medicaid enrollees. And so to contextualize this a bit, this is precisely why a policy intervention like extending postpartum Medicaid coverage is so central to our efforts to reduce poor maternal health outcomes among Black women and address racial disparities in this area. Next slide. So when do most maternal deaths occur? We know that about 31% occur during pregnancy, 36% during delivery and up to 1 week afterwards, and 33% occur 1 week to 1 year after delivery. Despite this, mothers lose their Medicaid coverage just 60 days after giving birth. Next slide. So as a review, Medicaid covers about 43% of all births nationally. Pregnancy-related benefits under the program are limited. They include prenatal care, labor and delivery, and postpartum care for just 60 days. Women and postpartum people are covered at about 133% of the federal poverty line in terms of their incomes. Next slide. So based on research conducted by the Century Foundation in partnership with the Commonwealth Fund, we examined the impact of Medicaid coverage loss for new mothers. We conducted qualitative analyses of public policy efforts in 3 states, Illinois, New Jersey, and South Carolina. We conducted document review, analysis of existing literature, as well as expert interviews, including interviews with new moms who had lost their coverage. We centered the experiences of these mothers throughout the research process. Next slide. So here are some of our key findings. The first is that Medicaid coverage loss leads to disruptions in coverage and insurance churn. Insurance churn is a concept whereby a person may move in and out of coverage during a certain period of time, or they may move between different health insurance plans. Coverage loss also leads to a lack of continuity of care and a loss of care coordination. And we saw this be really critical and harmful to high-need moms, those that may be experiencing substance use disorder and other chronic conditions. We also saw that it leads to a lack of access to contraception and mental health services. I think I also want to lift up here the fact that the moms that we interviewed in this process also mentioned not having coverage of doula care was a big issue for them. And I want to qualify that by saying that right now, doula care is only covered by Medicaid in a few states, and there is an effort in the broader sort of advocacy and policy space to ensure that more states are actually covering doula care for new moms. Coverage loss also leads to a mismanagement of chronic health conditions such as diabetes and heart disease. And it also leads to a lack of support for social services. Next slide. So our findings yielded the fact that continuity and coordination of care are paramount. Coverage loss can lead to further entrenched economic hardship for mothers. And we also know that racism, bias, and inequality impact care as well. You know, these are all issues and themes that came up throughout the process for this research project and conversations with both moms, providers, as well as Medicaid professionals. Next slide. So I wanted to share a story from one of the women that we interviewed in this process, Amber Pendergraft-Leak. Amber is a community-based doula based in South Carolina, a non-expansion state. And she herself lost coverage of Medicaid when she was, after she had given birth to her son. And luckily, Amber did not experience any serious complications or issues in that period where she had a lack of coverage. But she did share that most of her clients, which are largely Medicaid enrollees, largely young moms, have experienced some challenges after they lost coverage. So I'm going to click here and let you listen to a clip. This is original taping of when Amber and I talked, and she told me about this really sad story of a mom that she was working with. If we can click the little button at the bottom to play the recording. I think you might have to double click it. The bottom of the screen there, yeah. Is it not working? Okay. Okay, well, I can just read it for folks. Oh.
Sorry, it's taking me to a link that's not working.
Okay, so I'll just read it out loud for folks, and apologies for that technical error here. For one of my moms, the hospital had left a piece of the placenta inside of her. She bled out really bad. She ended up having to have surgery, but she still had the health issues from that. She actually passed out again after. And that was after Medicaid had got cut off. This health issue wasn't even her fault. It was the hospital's. She was able to get the help she had to pay. Her and her boyfriend had to end up spending quite a bit of money. Next slide. So based on the research that TCF conducted, taking a closer look at this issue, here are some of the recommendations that we came up with. The first is that we need Medicaid expansion in all states. And there are even some efforts at this point to close that gap in the 12 remaining states who have decided not to expand Medicaid. And I'm sure Alyson will get into some of that in her presentation. And obviously, we also want extension of Medicaid postpartum coverage to 1 year. We're also advocating for Medicaid reimbursement rates to be increased. From our perspective, we're asking for them to be on par with private insurance rates. We also want value-based care to be implemented. And some of this could mean linking payment to quality, making sure that for the providers that are offering patient-centered, culturally congruent care, that they are rewarded for that. And for those that are not, that they are held accountable. And last but not least, we want to address racism and bias in maternity care. And there are several ways that we can do that, including training providers to make sure that they are well-versed in how anti-racism should be implemented and how racism shows up in their care with patients, as well as an addition of lots of other ways to ensure that providers learn what this means and how it impacts their clients. And I think that's the last slide for my presentation. I'm going to pass things over to Alyson. Oh, one more slide here. Sorry, y'all. So if you want to read more about this issue, we have the full report with these findings on tcf.org. The report is Promoting Better Maternal Health Outcomes by Closing the Medicaid Postpartum Coverage Gap. Thank you. And now I'll pass things over to Alyson.
actually,
Yeah,
okay,
Angie,
go
if
ahead.
you could walk, no, if you could walk the folks through and I will get us situated technologically here.
Yes. So I'm not sure if any of you all have ever created a word cloud before, but we are going to go to, if you can, either with your computer or with your cell phone, if you can go to menti.com, and then it'll ask you to type in a code, and the code is right here on the screen, 36479345. And then it will ask you a question. I can do this. What are 1 to 3 words that describe your vision for birth equity? And if you can enter 1 to 3 words into those fields, Alyson will, are you going to take us to the website?
I am. I'm going to navigate us there shortly, but folks can
And I see a few
already.
people putting some questions in there, and we will get to those too after we do this activity. Yeah, people have it in there.
And the way this works is for words that people enter, multiple people enter the same word, those words will be larger. So a few folks have entered justice.
So the code is at the top, David. It's 36479345.
And you can also think about Dr. Taylor's presentation. We were priming you a bit for this question, right? Having Dr. Taylor give her presentation first, thinking about birth equity, thinking about reproductive justice. So some that are standing out to me, I'm seeing valuing all women, liberation, respect. That was one that came up for me. Zero disparities, persons. You guys are awesome. Person-centered, empower, equal treatment, empowered, listening, fairness, fulfilling, liberation. This is really lovely. And one of the cool things about this word cloud is we can save the image at the end of the presentation and post it. We'll post it as an image in the page for this workshop as part of the attachment. So feel free to keep, as you're thinking, please feel free to keep entering words that you think of. But thank you guys for engaging in this exercise with us. I will stop sharing the word cloud now, but again, feel free to keep entering.
And are there any questions for Dr. Taylor of clarification before we move on to our next speaker? It looked like somebody, hold on, let me see. Maybe that what folks are asking to learn about, that isn't really attached to Dr. Taylor's presentation, so we can take that towards the end. But please make sure, we want to make sure that all your sort of questions get answered, or at least we start talking about them by the end. But Alyson, I think we can move on to your presentation.
Great. So hi, everyone. I'm Alyson Northrup, Associate Director for Public Policy and Government Affairs at AMCHIP, the Association of Maternal and Child Health Programs, which is like a sister organization to City Match. Thrilled to be with you all this morning. So I have the pleasure of walking us through the policy lay of the land and getting into some pretty policy wonky details. I want to make sure that we're all on a level ground in terms of baseline knowledge about the pathways for achieving the policy we're discussing today, postpartum Medicaid extension. So I'm going to walk us through 4 pathways, and I want you all to keep in mind that this is all new. There have been a lot of developments over the past 3 years that have gotten us to this point where we actually have multiple ways of pursuing this policy of extending postpartum Medicaid coverage beyond the historic federal cutoff of 60 days from the end of pregnancy. So this first pathway that we're looking at is state-only funding. This actually is a mechanism that states could have been pursuing on their own, but has really only emerged in the last few years. So with each of these pathways, I'll kind of walk us through the details of how they work. So in the case of state-only funding, keep in mind Medicaid is a state-federal partnership. And so states pay for part of Medicaid administration, and the federal government pays for part of Medicaid programming administration. If states want to do something in their Medicaid program with just state dollars without a federal match, they have flexibility to do that, including extending postpartum Medicaid. They need to come up with the money to do it. So with pathway 1, states pay the full amount of providing Medicaid or CHIP, Children's Health Insurance Program, coverage after 60 days postpartum. And we did start to see some states doing this as this policy idea was kind of bubbling to the surface. The benefits covered. So Medicaid postpartum coverage could be narrow. It could be cover only certain conditions or visits. And if we're talking about state-only dollars, the benefit package is totally up to the state for what they would cover beyond those 60 days. The period of coverage after 60 days would also be totally up to the state. They could, just extend coverage for an additional 30 days, or they could do 12 months from the end of pregnancy or longer if they chose to. The effective date for pathway 1, in theory, always. In practice, California became the first state to pursue this approach in August of 2020, based on state legislation that the state passed in 2019. And just as a reminder, federal match, none in this case, it's state-only dollars. And in terms of what California pursued, it was the population of postpartum individuals that it covered for an extended period of time was limited to postpartum individuals with a diagnosed mental health disorder. Okay, pathway 2. This is where we start to get kind of wonky, and many of you may already be familiar with this, but I just want to make sure that we're all on the same page. Okay, pathway number 2 is called a Section 1115 demonstration. So this refers to Section 1115 of the Social Security Act, which enables the Secretary of Health and Human Services at the federal level to give states flexibility in how they implement their Medicaid program. It allows them to innovate. It's meant to be experimental or a demonstration project to explore something new within the bounds of promoting the objectives of the Medicaid program and being quote unquote budget neutral to the federal government. So this is important. It cannot cost more than what the state would otherwise be doing over a designated budget window. And it's meant to demonstrate and evaluate state-specific policy approaches to better serving Medicaid populations. And generally it's for a 5-year period, though it can be renewed. So in terms of using Section 1115 demonstrations or waivers for postpartum Medicaid extension, the mechanism is that a state submits a waiver to CMS, the Centers for Medicare and Medicaid Services. They can propose a benefit package that is variable. It could be comprehensive Medicaid benefits in the postpartum period, or it could be more narrow. Again, for example, only covering women with a diagnosed substance use disorder for a diagnosed mental health disorder. The coverage extension period that a state might propose, again, could be variable. It could be 6 months. From the end of pregnancy, it could be 12 months. This is a new pathway for pursuing this policy. The effective date, CMS approved the first Section 1115 waivers to extend Medicaid in the postpartum period beyond 60 days in April of this year. So this is new. States have been working on this for a couple of years, but it did not become approved and a viable pathway for states until CMS issued those first approvals in April 2021. What this does is it enables states to cover postpartum individuals beyond 60 days from the end of pregnancy using state dollars and receive their standard federal matching rate. So this approval brings in federal dollars. All right, the third pathway, this is also brand new. So this is a state plan amendment. This is another way that a state can make changes to how it administers its Medicaid program. This is, again, a formal mechanism for states to change how they implement their Medicaid and CHIP programs. It's more streamlined than the waiver process. So once a state submits a SPA or state plan amendment, CMS has a limited amount of time where they have to approve or not approve this state plan amendment request for a change. And so it essentially forces CMS to make a decision in a shorter amount of time. If they don't make a decision in that 90 days, they can request an extension, like they can request more time. But otherwise, the proposed change automatically goes into effect. And generally that approval is not time limited. Like with the waiver, it's generally 5 years. The SPA is more long-term. Okay, so the SPA for postpartum Medicaid extension, again, brand new. Congress enacted a new state option as part of the American Rescue Plan Act in March 2021. So the American Rescue Plan Act was this big legislative package focused on COVID relief. And it included this policy that had been in the works for a very long time, separate from COVID, but was attached to this COVID relief bill. And that enabled states to submit a state plan amendment that complies with specific federal standards laid out by Congress. So those standards, if a state wants to submit a state plan amendment and have it approved by CMS to extend coverage for women in the postpartum period on Medicaid, the benefit package must be comprehensive. It is a full Medicaid benefit package. It must be for 12 months from the end of pregnancy. And so those are two really big important details. So what this does is Congress established federal guardrails for states to pursue this more streamlined approach to extend postpartum Medicaid coverage. It's not in effect yet. It was passed just in March. It takes effect April 1st, 2022. And just this week, the Centers for Medicare and Medicaid Services released guidance to states on how to do this and get the approval for the SPA. This was part of the Maternal Health Day of Action on Tuesday this week, led by the White House and Vice President Kamala Harris. And so this was a really big development towards implementation for states of this new state plan option or state plan amendment option. And there is a federal match, and it's the standard federal matching rate. So states can, if they submit this SPA and it complies with the guardrails set out by Congress, CMS will likely approve it. States would cover to 12 months with a comprehensive benefit package and receive their standard federal matching rate. Okay, so I said there were 4 pathways. There's really only 3 right now, but we could see a 4th pathway in the coming weeks. So that would be a mandated benefit. And so There is, as part of the Build Back Better Act, a proposal to, or provision rather, to require states to provide comprehensive Medicaid benefits through Medicaid and CHIP to 12 months from the end of pregnancy. And that would be effective January 1st, 2023, if it's enacted, and it would include the standard federal match. So it's sort of a pathway, but it's also like states would just have to do it. So it's not like an option to pursue. It's just, it is, if the Build Back Better Act passes, which is this big, social infrastructure proposal out of the Biden administration that's snaking its way through Congress, that we could see pass before the end of the year. If that passed, and it does at this moment include this provision, states would be required, it would be the federal standard to provide postpartum individuals on Medicaid and CHIP with coverage, comprehensive coverage through that full first year postpartum. This is really just a kind of an easier way to look at what these pathways look like and matching up sort of the mechanisms. I'm not going to go through it because I just went through the details, but I wanted you all to have this in the slide deck. And here's where we are right now. So this map, I use this map all the time. This comes from ACOG, the American College of Obstetricians and Gynecologists. They have a great team that's been tracking all of the state level and federal level activity related to this policy. And so you can see that there are a lot of states who are actively pursuing postpartum Medicaid extension. Even before the American Rescue Plan Act and even in anticipation of a potential mandate, states, red and blue, Medicaid expansion and non-Medicaid expansion are pursuing this policy. Just one note. So obviously we're in COVID times. We're in an officially declared public health emergency. And another provision that passed as part of the American Rescue Plan Act back in March 2021 was if states wanted to receive enhanced federal funding under Medicaid, which is part of the American Rescue Plan Act, they had to commit to not disenrolling anyone from their Medicaid rolls. That includes postpartum women. So while we are in this declared public health emergency, we are in a de facto postpartum Medicaid extension period. And so while this is ongoing, these individuals are covered, which is great. At some point, the public health emergency will end. We all hope and pray that that is sometime relatively soon. And so I just wanted to note that, and we would hope that there would be continuity. So when the public health emergency ends, for individuals who would then be eligible for postpartum Medicaid coverage under a Section 1115 waiver or a state plan amendment, which you guys know all about now, or a mandated benefit, that there would be a continuity of coverage so that those individuals don't lose their coverage during the postpartum period. Okay, I'm nearing the end of my wonky portion, then we can get back to more like fun narrative stuff. Okay, so this is just a really cool thing in my mind to show how far we've come in just a few years on this really critically important foundational policy. So in 2017, we had no states or introduced federal legislation considering ways to extend Medicaid and CHIP coverage beyond 60 days postpartum. Here we are in December 2021, and look at all the activity there is. 37 states have undertaken efforts to extend. 5 states have waivers approved by CMS to extend coverage beyond 60 days from the end of pregnancy. Additional 2 states have waivers pending. 17 states have indicated they plan to implement either a waiver or the state plan amendment, newly available in April next year. There are 7 federal bills that propose postpartum Medicaid extension in some form, way, shape, or form. Congress, as we talked about, enacted this state plan option, and Congress may soon pass this mandatory comprehensive coverage benefit. And so how did we go from 2017 to December 2021? In part, I'm going to let my colleagues talk about what that looked like in Illinois, an Medicaid expansion state, and in Georgia, a Medicaid non-expansion state, and some of the politics and personalities that led to advancing this policy at the state level. And then during the facilitated discussion, we'll get to some more considerations, and maybe during Q&A about what kind of pushed this at the federal level as well. And then just really briefly, one of the tools that states and at the federal level we used was this toolkit. For state advocates, there is a federal resource as well for making the case for why this policy matters, some of the cost considerations, some of the projected benefits of this policy. And this toolkit is in the workshop resources. It's definitely worth a read. It's from June 2020, but a lot of the research that it pulls together is still relevant. The messaging is still relevant, and it's information that you can share as an advocate and also as someone within state government, city government, to help illustrate why this policy matters. And with that, I'm going to turn it back to Angie to walk us through an activity.
Yeah, so if you guys remember, Alyson shared this slide with us. We thought it would be interesting, and I know you all have already put what state you're from, and I'm impressed that there are people from the West Coast on this early in the morning live. If you all know how to annotate, let me tell you, if you can go up to the top where it says view options at the top, and you pull down, and then it should say annotate, and then you can get whatever stamp you want. If you are engaged in your state in any kind of advocacy efforts or providing data to a group that might be interested in extending Medicaid coverage for pregnant women, put a star on your state. And I see some people are putting hearts already, but I don't know if that means they're engaged or not in Illinois. But if you're put a star on your state. Okay, Arden. If you're engaged in that, put a star. If you're just interested in learning more, then put an X on the state that you're from. Does everybody understand how to annotate? So I'll put a star, even though I don't know how. I'll put a star on Georgia. So and Arden has already put hearts on Illinois. So if you all could do that. And if you're not engaged and you're just here to learn, that's fine too. You put an X on your state so we can see where everyone's from. I see Charisse is not able to annotate. Is anybody else, are other folks having trouble annotating? Okay. Well, somebody did it over there. Okay, people are putting hearts. Okay. People are not able to. Okay. All right. Is there anybody in their state? Oh, somebody even wrote stuff on there. Is there anybody who is engaged in their state activities who wants to share how they've become engaged? I think some folks said that they were. Teresa, do you want to say how you're engaged? You want to unmute yourself and talk a little bit about how you're engaged in the process in Pennsylvania?
Can you hear me?
Yes.
Hello. Okay. Hi, I'm Teresa Petaway from Petaway Pursuit Foundation. And we are involved not only from the standpoint of helping with the process of doulas. We provide doula services, and we're the Pennsylvania Doula Commission. But my organization is actually one of the first in the country that have had Medicaid reimbursement since 2007. So I'm here in Pennsylvania, and we've been doing so, and so we're helping the state now be able to write up the policies and procedures for our state.
Wonderful. So not only are you interested in the postpartum extension, but you all have figured out a way forward for the doula cover, the doula reimbursement that Alyson mentioned that some states were pursuing also. That's great.
So my organization itself has been being reimbursed, and we were not just in Pennsylvania. We have been reimbursed in Pennsylvania, Massachusetts, and Rhode Island. So my organization itself had reimbursement from those organizations before all of this took place.
That's wonderful. Okay. Can whoever put the star, there's a few other stars on here. It looks like Virginia, someone put a star on Virginia. I don't know if that was one of our panelists or if there's another person in Virginia that's been engaged in their waiver. Who wants to share?
I put the star in Virginia.
Okay, you did. Okay. I was afraid it might be one. Now there's some star over here. I don't know if that's, if folks are putting stars where they live. It looks like it's on the border of Montana and oh my goodness, those square states are hard for me. What is the state that's right below Montana?
Wyoming.
Wyoming. Is there somebody here from Wyoming that's engaged in or trying to start something in Wyoming?
I also saw, I don't know if Marina, if you're
Yes.
interested in unmuting, but Marina shared that she's engaged in data analysis and research and communication with Medicaid in Wisconsin. If there's anything you would want to share about your experience, please feel free to unmute as well.
Yes.
Yeah, I can share. I've been doing research at the University of Wisconsin-Madison, and we have Medicaid enrollment data linked to birth records. I have a presentation in another session related to that. And we have been presenting some of the results to people from Medicaid each year for the last couple of years. So I've just been doing research and then just discussing it with them, basically.
That's wonderful. That's a great way for stakeholders to get engaged in the processes to share data. So I think we'll probably move on to our two state examples, and they're going to give you the full story of how it happened in Illinois and how it happened in Georgia. And then, then we'll move to the Q&A part. So Arden, do you want to give Illinois' story?
Thank you, Angie, and thank you to all of my colleagues for presenting today, and thank you to City Match for really a terrific conference. It's been quite inspiring to attend all these sessions, and we're hoping next year when we're hopefully in person in Chicago, we'll all get to see each other. I'm going to give the story of postpartum Medicaid extension in Illinois. This is the story of many, many stakeholders. I'm just here today because of my role in I Promote Illinois, the Illinois Maternal Health Task Force. Next slide. And my role as maternal and child health advocate through my long-standing position at the University of Illinois School of Public Health and the Center of Excellence in Maternal and Child Health. The work presented today is, and my work in maternal health is funded partly through the HRSA grants that I have through the Maternal and Child Health Bureau, but what I'm presenting today does not represent the official views or the endorsement of HRSA or the US government per se. Next slide, please. So I wanted to start my presentation with this slide, which lays out the Kingdon policy agenda. and how policy gets made. And I want to make sure that I shout out to my friend and colleague, Kay Johnson, who put the initial version of the slide together. But I always talk to my students in my maternal and child health policy and advocacy course about the fact that policy doesn't get made just because we're good people or we think it's the right thing to do or it's just, but it's really because we have a confluence of factors that come together. And we talk about the Kingdon policy windows of opportunity, where the problem stream meets the policy stream, meets the political stream. And with the case of maternal health and the postpartum Medicaid extension, this is a perfect example of these streams coming together to open this window of opportunity for action. And I'll give you the details of how this played out in Illinois, but I love this as a wonderful case study. Next slide, please. Sorry, I'm stopping because I keep on getting the chats in my window and I have to shut them so I can see. The context in Illinois, I wanted to give a little background. There had been lots of work and there's been a long-standing maternal mortality review committees in Illinois. But the problem stream really came to light more clearly and more clearly explicated in 2018 with the publication of the Illinois Maternal Morbidity and Mortality Report by the Illinois Department of Public Health. Next slide, please. This report, which was based on 2015 data, as you know, data sometimes lags, was based on the work of two maternal mortality review committees. In Illinois, we have the main maternal mortality review committee, the original one, and then a new committee that is focused on what we call violent deaths, really focusing on homicide, suicide, and drug overdose. And these two committees review deaths, and they use the expanded definitions of pregnancy-associated death, the death of a pregnant or birthing person during pregnancy or within 1 year of the end of pregnancy from any cause, and then work down to pregnancy-related deaths, the death of a pregnant or birthing person during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by the pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. Next slide. So based on the 2015 data that were in the Maternal Morbidity and Mortality Report, we found that Black pregnant persons in Illinois were 6 times more likely to die of a pregnancy-related condition than non-Hispanic white pregnant persons. In addition, 72% of pregnancy-related deaths and 93% of violent pregnancy-associated deaths were deemed preventable by the review committees. Next slide, please. Importantly, the timing of these deaths was very poignant. 51% of the pregnancy-associated deaths occurred after 60 days, between the 61 to 364 days postpartum, and 34% of the pregnancy-related deaths occurred in that window of 61 to 364 days postpartum. And the leading causes of death in that extended postpartum period were mental health conditions, including substance use disorder and postpartum cardiomyopathy. Next slide, please. And we found in this report, again, based on 2015 data, 71 of the pregnancy-related deaths that occurred in that late period were potentially preventable. And the report cited both poor continuity of care, which Alyson talked about as well as Dr. Taylor talked about, and the lack of care coordination contributing to the deaths in 93% of the pregnancy-related preventable deaths during that window that was in the period after 60 days postpartum. Next slide, please. So with that information in hand, the Illinois Maternal Morbidity and Mortality Report in 2018 calls for the expansion, and now we're calling it extension, of Medicaid eligibility for the postpartum period from 60 days to 1 year. So a very important recommendation comes out in 2018. Just trying to set the policy context now. Data to action. Next slide, please. You know, as you know, reports come out all the time and they could just be sitting on the shelf. But so many things came together to lead to the adoption of the postpartum Medicaid extension waiver in Illinois. But before we get into that whole story, I want to give you a little sense of the policy context. Illinois is a Medicaid expansion state. In addition, Medicaid covers 44% of the births in Illinois, but only 56% of Illinois birthing persons on Medicaid have a postpartum visit. So even though we were working on the postpartum Medicaid extension, we also have a problem just getting people to that postpartum visit in the coverage window, essentially. And in this picture, which comes from the report that Alyson showed us at the end, that's the AMCHIP, ACOG, March of Dimes toolkit. This lays out the situation prior to the postpartum Medicaid extension. It tells the story of Mia, who has coverage during pregnancy, who has coverage up to 60 days postpartum, but because her income is less than what was covered during pregnancy, which was 213% of the federal poverty level, and her income's at 150, she would lose coverage at 60 days postpartum and have to negotiate and navigate onto the marketplace and try to get a plan that was expensive and oftentimes not even getting a plan. Next slide, please. More specifically, just laying out the postpartum Medicaid extension in Illinois. The two rows are before the postpartum extension and after. And essentially, the coverage gap was here. Folks were eligible for pregnancy coverage up to 60 days postpartum, less than 213% of the federal poverty level before the extension. But we're losing that coverage, and only those eligible up to 138% of the federal poverty level would be able to continue to get coverage in the period after 60 days. With an extension, all those less than 213% of the federal poverty level could be covered after 60 days. Next slide, please. So we have a response to the maternal mortality report, which was kind of amazing. The Illinois General Assembly extended Medicaid coverage for pregnant persons from 60 days to 12 months postpartum, effective January 1st, 2020, when the chair of the Appropriations Human Services Committee, my friend and colleague, Representative Robin Gable, longtime maternal and child health advocate in the state of Illinois, added, really late at night, to the Budget Implementation Act for Medicaid this provision. And the governor signed it into law on June 5th, 2019, and it required that the Illinois Department of Healthcare and Family Services, as we call HFS, to seek federal approval for this implementation of this extension. Next slide, please. So in response to Representative Gable's putting this in the budget, which we were all thrilled with, like, how is it going to get funded? Was this really going to happen? Our state Medicaid agency, HFS, submits a concept paper in 2019 in the summer to CMS. And in the original concept, they said they would like to cover all persons, pregnant persons and postpartum persons in Illinois, 60 days to 12 months postpartum, regardless of immigration status. And the Trump administration responded, they'll not approve any extension for undocumented immigrants, and they were not sure how they felt about immigrants who were still in the 5-year waiting period. Okay, so then comes December 2019. In response to that, the state submits the 1115 waiver, as Alyson just described, and they included in that waiver citizens, qualified immigrants, and immigrants in the 5-year waiting period. The qualified immigrants included those who had already passed the 5-year waiting period. The undocumented immigrants were removed from their request. Trump administration comes back and says, we'll approve a narrower waiver. We just want to approve something that, you know, for persons, for example, they said something like, with identified mental health issues can get the coverage extended. And the state of Illinois, to its credit, and the state Medicaid agency said, you know what, we don't like this. This doesn't speak to us of equity. We're really concerned that this kind of coverage is disproportionately going to provide coverage to white persons, and it's not going to address the significant health disparities and inequities faced by Black persons and people of color in our state. So they did not go forward with the waiver, the shortened waiver or the less extended waiver that the Trump administration was offering. Next slide. So lo and behold, the administration changes and we have Black Maternal Health Week, and the CMS announces that Illinois is the first state to have their waiver approved. And this was going back to the original waiver, not the truncated waiver that the Trump administration had proposed back to the state. And so you see HHS Secretary Becerra announced Illinois first state to provide continuity of full Medicaid benefit coverage for mothers by offering extended eligibility for a woman during the entire first year after delivery. And here I'm quoting from the press release that came out that week, that day. Next slide, please. So it's never like that simple, right? So it's not completely over. So the waiver follows the standard Medicaid eligibility rules with respect to immigrants and covers the citizens and says, okay, we're going to cover the qualified immigrants who meet the 5-year waiting period. The Biden administration wanted to cover others, but felt like the 1115 waiver process would not allow them to do so. So they come back to the state and they say, okay, we'll work with you. You can apply for what's called a CHIP Health Services Initiative State Plan Amendment to extend coverage to immigrants who didn't qualify under the 1115 waiver. And then in September of 2021, just 3 months ago, the state got an approval from CMS to cover immigrants, both the undocumented immigrants and immigrants who had not yet met the 5-year waiting period. So really the details of this, the nuance of all the back and forth and negotiation that goes on with CMS shows you sort of how intricate this policy development really is. Next slide, please. This waiver is essentially going to cover an additional almost 10,000 persons per year with an annual cost of about almost 50 million per year with both the federal and state together. We're getting the federal match for our state dollars. And you can see actually that a lot of the additional months are going to be for the CHIP HSI waiver, which is for the undocumented and for those who have not passed their 5-year waiting period. And just as you know, as Alyson mentioned, we're still in the public health emergency. The waiver may not really go into effect depending on when the public health emergency ends. And the Illinois HFS department is planning to apply for the SPA. So we may never go into effect with the waiver. We may go right from the PHE into the SPA. We'll see what happens. And then there might be a mandate coming out of the next few weeks. We'll see what happens there as well. Next slide, please. So Illinois is like, rocking and rolling. It's just a very exciting time. So this is not the only thing that's happening. I just wanted to let you know that we've also passed Medicaid coverage for doula care. We're in the middle of figuring out what that means because it does not just specify certain kind of doulas. And so there's a lot of advocacy right now trying to make sure that all kinds of doulas are covered. And we're working on what's training, what's certification, what's competencies, and community-based doulas versus agency-based doulas. And it's an incredible discussion happening in our state right now. There's also passing the Black Health Pillar bill that this refers to, also passed implicit bias awareness training for anyone getting their licenses renewed. We also had this incredible movement to pass certified professional midwives, giving them licensure, which is a huge deal. It's been up many, many times, never passed before, and passed in this spring legislative session. Next slide, please. We also expanded our birth center activity. 2 bills passed. We put in a bill that we wanted to get passed to expand the number of birth centers we can have in Illinois. Illinois has been operating under a demonstration project forever for birth centers. But we said, okay, let's go full tilt and also put in for the full 9 yards and see if we can get a birth center licensing act. And lo and behold, both passed. So eventually the first bill is going to be superseded by the second bill. But right now we're in a birth center explosion in Illinois. Next slide, please. And we also, okay, next slide. We also passed 2 Medicaid coverage for 2 postpartum visits, one in the first 3 weeks and then one 4 to 12 weeks with also extension of the postpartum Medicaid screenings for depression through the 12 months postpartum. And also this bill also talks about postpartum reimbursement for all kinds of providers. And it's probably interrelated with that doula expansion. We had a lot of legislation. Some of it overlaps with other legislation. We're working it all out at this moment. Next slide, please. So I just want to say, okay, I gave you all that. What were the confluence of factors that made this happen? Certainly the changing environment with respect to maternal health, all of the data that's being presented on the state level, the national level, et cetera. Two of the strongest federal advocates for maternal health changes are in our state, Representatives Robin Kelly and Representatives Lauren Underwood. Lauren Underwood with the Mama to Best Act and Robin Kelly with the Mamas Act, and just incredible advocates on behalf of maternal health. An incredibly progressive state legislature with the Illinois Legislative Black Caucus, passing bill after bill with very progressive people of color allies, and all kinds of folks working together to make sure this stuff happened, including the Illinois Department of Public Health with the maternal mortality and morbidity report and a subsequent report published in April 2021. I Promote Illinois, which is the Maternal Health Innovation Project, which has the Illinois Maternal Health Task Force. We have another task force on infant and maternal mortality among African Americans, which we affectionately call IMMT. We have Ever Thrive Illinois, that's our maternal and child health advocacy group. We have this incredible prenatal to 3 initiative that also talked about postpartum Medicaid extension. And we have a Medicaid agency clearly committed to equity that refused to adopt the Trump CMS offer and waited till a change of administration to adopt a full-blown Medicaid extension. And that is, I believe, for me, and I'm more than happy to take questions. And putting this together, I want to thank Laura Phelan from the Health HFS, who helped me with all the details, because I thought I knew everything, but I obviously knew nothing. And Laura was incredible. And to all my partners in Illinois who really did all the work to get this Medicaid postpartum extension passed. And I'll, I think, turn it over to Sashoy Patterson, who's going to talk about Georgia. And I don't know if there's any questions specifically for me right now, Angie, or we want to just wait. Okay, we'll just wait.
I don't think so. Yeah, let's
Okay, great.
Sashoy, because I think it's great to hear from a state that hasn't expanded Medicaid and what this postpartum extension means for them, because there's probably folks from both camps. Sashoy?
Yes, thanks, Arden. Hi, everyone. My name is Sashoy Patterson. I am a research associate at the Georgia Health Policy Center, and I'll be sharing Georgia's story on Medicaid postpartum extension. Next slide, please. Excuse me. So just a quick background on Georgia's Medicaid program. It covers 50% of all births in the state. In state fiscal year 2020, Georgia Medicaid covered about 111,000 pregnant women and about 70,000 births. And our CHIP program for individuals under age 19 also covered about 80 births. Next slide. So Georgia had been previously identified as one of the states with the highest maternal death rate in the nation. If you look at the chart on the right, it shows how Georgia's maternal mortality rates compared to national rates across years 2013 to 2017. Maternal mortality in Georgia was about 2.5 times higher than that of the national maternal mortality rates. The chart on the left shows how Georgia compares to the nation when maternal mortality rates are broken down by race and ethnicity. The trend is about the same across the two, except that in Georgia, Asian women had a higher maternal mortality rate than Hispanic women. And as you can see at the top, Black women have an exceedingly higher rate of maternal mortality than all other women nationally and within Georgia. And overall, it just shows that all women, regardless of race and ethnicity, were doing worse in Georgia versus nationally. Next slide, please. So Georgia have been concerned about our maternal mortality rankings and established a maternal mortality review committee to study the issues surrounding maternal mortality. I apologize that the infographic on the right is a bit small and hard to read, but I'll point out some of the main areas. So the infographic shows that the committee's most recent report, looking at data over 5 years, and of the maternal deaths reviewed, 66 per 100,000 births were pregnancy associated and 26 were pregnancy related. To reiterate, pregnancy associated is a death during pregnancy or within 1 year postpartum due to a cause not related to the pregnancy. and pregnancy related is a death during pregnancy or within 1 year postpartum from pregnancy complication or a chain of events initiated by the pregnancy. So the MMRC found that 70% of the pregnancy related deaths were preventable and that Black women were 2.7 times more likely than white women to die from pregnancy related causes. Looking at the chart on the right, there were 99 pregnancy related deaths 1 to 60 days postpartum, which is the normal Medicaid coverage period. And if we look down to the 181 to 1 year postpartum, the period that we're interested in for Medicaid extension, there were 117 pregnancy associated deaths. And at the bottom of the infographic, the committee had several recommendations, including extended Medicaid coverage up to 1 year postpartum. Next slide, please. Recognizing that maternal deaths are a serious public health concern, the House Study Committee on Maternal Mortality was created by House Resolution 589 during the 2019 legislative session. So the Maternal Mortality Review Committee's suggested preventable deaths influenced the House Studies Committee call to action, recommended continued review of maternal deaths to understand the trends in the data and the need to develop strategies and institute systemic changes to decrease and prevent maternal deaths in Georgia. So the study issued a final report. They looked at 3 years of maternal death data, and they reported that 60% of the deaths were preventable. They also listed about 20 recommendations, including extending Georgia Medicaid to 1 year postpartum. During this time, the Georgia Health Policy Center also held an educational session with legislators, and they identified maternal mortality as their top area of focus. We then gathered a group of stakeholders to build a systems model to help folks understand how the whole system comes together. The data behind the model highlighted variables that affects the system. And we are unclear of how these actions contributed to the results that we're discussing today. But the point is that a lot of work was put into this topic. I believe this tool is still in the fine-tuning stages, and it may be available for dissemination soon. Next slide, please. So the high rate of maternal mortality continued to be a pressing issue for the state, and the Georgia General Assembly advocated for the passage of House Bill 1114 during the 2020 legislative session. The bill was signed into law and has 2 provisions. The first one authorizes extension of Medicaid coverage for lactation services to pregnant and lactating women and their children, which would be implemented under the state plan amendment. The second authorizes extension of postpartum Medicaid coverage from a period of 60 days to 6 months and would be implemented under the 1115 waiver demonstration. Next slide, please. So in direct response to the House bill, the 1115 waiver application was submitted in December of 2020 with the goal to provide continuity of care for new moms to ultimately reduce maternal morbidity and mortality. So the waiver was approved in April of 2021 to be effective July of 2021. But as we stated, we are currently operating under the public health emergency. And to add, Georgia is considering transitioning to the state plan amendment following the public health emergency. And I'll talk a little bit more about that later in the presentation. Next slide, please. So this is just a quick summary of Georgia's proposed 1115 waiver goals, hypotheses, and metrics. The main goal of the waiver is to reduce maternal morbidity and mortality for Medicaid members in Georgia. And the hypothesis is that extended coverage will reduce maternal morbidity and mortality by providing continued care and care coordination. The metrics that will be used to evaluate the implementation include rates of maternal morbidity and mortality year to year. They'll look at the number of women who access services pre versus post implementation, and they'll also look at postpartum visit rates pre versus post implementation. Next slide, please. And this is a snapshot of a resource that my colleague Angie and I created under the Maternal Health Learning and Innovation Center project with UNC, AmChip, and other partners. We looked at states with pending or approved 1115 waivers and summarized their waiver goals, their metrics, and their evaluation plans. This tool would serve as a good resource for other states who are considering this route as well. If you would like to access this tool, the link is included here in the slides, and it is also uploaded into the City Match platform. Next slide, please. So eligibility will not change for the 1115 waiver extension. Beneficiaries will continue to receive care for the additional 4 months. And at the end of the extended coverage period, they will then transition to the appropriate Medicaid program. Next slide. So the 1115 waiver will cost about $155,000 in year 1 to $186,000 in year 5 additional member months. It will also cost an additional $368 to $440 in per member per month costs. DCH or Georgia State Medicaid was appropriated about $60 million for the increased per member per rate cost over the additional 4 months of the waiver. Plus, there will be that provision from the FMAP rate, which is now 73% in Georgia. This is actually a 6.2% increase in the FMAP rate, and this was an increase across all states under the Coronavirus Response Act. Our previous rate, I think, was about 68%. So overall, this waiver will total about $104 million, including state and federal funds combined. Next slide, please. So Angie and I had a conversation with our Medicaid director of 20 years about the state's rationale around the 1115 waiver. And here are some of the questions that we discussed. We talked about what was our state Medicaid's role in the waiver, and their role was to assist in drafting the application. They made sure that the systems were updated to sustain the program and made CMOs aware of the upcoming change. Why did we do a 6-month extension versus 12 months? Well, money was definitely a driving factor. We were only awarded enough money to support a 6-month extension. There were 3 to 4 bills for a 12-month extension, but none passed. The original 12-month bill got cut back to 6 months, again, solely based on cost. Next slide. Then we talked about why did we do an 1115 waiver versus the state plan amendment. Well, the state plan amendment is not an option until 2022, and Georgia wanted to implement the plan earlier. However, the state plan amendment is, operationally easier, but there is that extra financial need to support this option. And 1115 waivers, they do require more evaluation and reporting. And for those reasons, Georgia Medicaid is considering transfer to the state plan amendment at the end of the public health emergency. But again, this will require more funds as the state plan amendment requires a 1-year extension versus the 6 months that we're currently doing. And we will also have to consider reapplying for another 1115 waiver demonstration after the state plan amendment expires, unless Congress reauthorizes the state plan amendment. And that's all I have for today. Do we have any questions? Or Angie, we're going to move into the facilitated discussion.
Yeah, and I know we don't have a ton of time left, so I don't know if we want to hit the questions that the audience has, if they have any before, because I have plenty to ask, but I don't want to take we only have 10 minutes left, so I don't want to take the time. I know that we had a question about and why don't I let the panel address the question that came up, which was, do you guys think that the administration change, if it changes back to a more conservative administration after the Biden administration, if that will have an impact on any of these options, Alyson, that you talked about? You all want to talk about that?
Yeah, I think it's a great question. I didn't know about the details that Dr. Handler shared in terms of the back and forth between Illinois and the Trump administration CMS, and that Illinois had made a strategic decision to kind of wait it out and see if a Biden administration would be supportive of a more expansive waiver. And I think that is a strategy that states take. During the Trump administration, we saw more conservative states pursuing limitations to Medicaid, adding in work requirements. And so I think there is always that back and forth and that balance. What I would note that seems to be different about this policy is that, and there's a bit of discussion about this in the chat, to a certain extent, it is transcending traditional partisan divides. I think we have gotten to a bit of a tipping point with this policy where there is fairly broad acceptance about the rationale and the need for this policy. We're now seeing additional reports coming out about the actual cost of the system as it is, where postpartum individuals lose coverage at 60 days from the end of pregnancy. And that versus an investment in this coverage is actually cost effective. That can be a really effective argument in more fiscally conservative states. And I just think that there's general broad acceptance that this is important and we should be supporting this in the United States and providing this coverage. And so, I think it's possible that if we were to fast forward, 3 years from now, and we had a change of administration, maybe, and we didn't have a mandate, right, a mandated benefit, maybe you would see states scale back their coverage or move away from this policy some, but I think by that point, we might actually see broad acceptance. And I'll let Dr. Taylor chime in as well.
Yeah, I would just say too, I don't want to give conservative states and politicos that much credit. I love and respect Alyson and, all of her contributions to the policy space. But I think, another thing that we're seeing in these trends is that, the states that do decide to take this up, the support is very limited in terms of like the suite of services that are provided in that extended postpartum period. They want to limit it to, substance use disorder treatment or mental health care. They want to limit it, the time, it may be 6 months or, 3 months or what have you. So I do think it's important to sort of put that out there. We're not talking about conservative states or conservative policymakers that are supporting the full spectrum of comprehensive, maternity care, reproductive health care, all types of care that a person would need in that postpartum period, in addition to a full 12-month extension. So did want to qualify that a bit.
Yeah, and I would like to sort of agree with Dr. Taylor that, in some ways, this is an easy win for these states. And the same states are completely suppressing voting rights and doing all this other terrible stuff, but they can say, oh, well, we were good on maternal mortality. And I think this has become we're not going to expand Medicaid, but we'll do this. And I think this is sort of like an easy political win. And, in some ways, it's a cheap shot. It certainly benefits all pregnant and birthing persons, but it's clearly just, to me, it's like they're willing to go this far, but certainly not the whole 9 yards to support birthing persons.
You all make a good point, but you could see the difference between what it costs in Illinois, who's already expanded Medicaid, because you're just talking about, the difference between 133%, a very small swath. And you talked a lot about your immigrant population, right? And then how much it costs in a state like Georgia who hasn't expanded. Big differences for the, for the state to come up with the state share of the funding. So you guys are completely right that there's a different conversation and a different discussion going on in a state, depending upon a lot of contextual factors in that state, for sure. So is there the things that I had scanned through in the chat, I think we touched on a lot of them. Like, a lot of you all were coming to learn more about implementation, and you can see that there's a ton, especially like what had to happen in Illinois, that the Medicaid agency and individuals that work for Medicaid agencies have to do in this process. There's a ton that the advocates have to do, and all of you all that are data gatherers, and you can see, Sashoy gave an example and Arden gave examples of how that data was shared back with the important policymakers. I think there were a few questions. A few of you all said you really wanted to learn more about how to communicate this policy. So I don't know if the panelists want to say anything to that effect, like how best can states that have changed this policy, how well can that be communicated to the individuals that need to know about it, and how can that go as fast as possible? Do you all have any thoughts about that you want to add before we wrap up?
I think that's always tricky. We have all these policy changes in Illinois right now, and we're trying to figure out how to do a social media campaign around them, and also to make it so that people are interested in this, social media, like how do we make this, it seems so dry. So we're struggling with that now. We have a communications group of our Equal Access to Care subcommittee of our Illinois Maternal Health Task Force that's working on a social media plan to try to get out this information. But I don't think it's that easy to get out. And I remember way back, in the late 80s and 90s when we had our first Medicaid expansions, just letting people know that they were now covered. It takes money, effort, et cetera. It's one thing to provide coverage. It's another thing to let people know that they actually have this coverage and that they can continue on with coverage. I mean, I think it's going to be an uphill battle for everybody to do this and do it effectively.
Yeah, just to build on what Dr. Handler said, I agree with all of those things. I think also when it comes to making sure that, women who would benefit from this policy change know that, it is now in place. I think working with other social service entities, and pediatricians, thinking creatively about the fact that, these new moms are going to be going to, these other places for the rest of their service needs and benefits. And so thinking through how the communication about the Medicaid postpartum extension could be offered through those channels, I think could be really impactful.
That's a really good point, Dr. Taylor, because like you were saying, some of the states are like Georgia, even though it's conservative, full Medicaid coverage for these women, complete. I mean, they get the same Medicaid coverage as everyone else. So I think Kay made a good point in the chat too, that in states where they're getting full Medicaid coverage, thinking about all the other services that these women might need, and how do you package that so that it's really targeted to postpartum women, and how do you let them know that those services are available, and how do you get them connected? That's really important for all you all folks, the folks of you that are on the ground and doing this work on a day-to-day basis. And then one last question before we end is, I'm sorry to see who was this asking the question, but they were asking about if they wanted to get in touch, connected with people doing research in this area. Arden or Dr. K, do you guys have any ways that you would recommend folks doing the work can get connected to the folks doing the research? Because I do think you're right. That's important for us to give feedback on how these early adopters are, what's happening in those states where they've adopted this, and how can we spread the evaluation results? Do you guys have suggestions,
Yeah,
Dr. Taylor?
I mean, we're just trying to figure out this evaluation. The problem when you have expansions or extensions is, as you know, people in the post or not in the pre, and trying to figure out what data sets we can use. And we're really struggling with this, trying to, what are the, what measures are we going to use? But I do think that, as we figure that out and as we get data, of course, everyone's going to want to be sharing it. And I think any work that people are doing around this needs to be, widely disseminated through not just through peer-reviewed journals, but for all the policy think tanks and through, Alyson's work, and the toolkit, Alyson in particular, is, so helpful. And now maybe can be a part two, like, the experiences of states that are going through this kind of thing. I think that these evaluations are, to me, tricky. They're not the easiest to do.
And just one additional resource that I'll mention and then let Dr. Taylor speak is the AmChip Innovation Hub, which is like a step before you would get to anything peer reviewed, where it can document policy development, policy implementation, policy evaluation with a focus on centering equity in each of those three cases. And there's also a programmatic track for maternal and child health innovations. I'll put that into the chat, but that can be an initial way to document process and success. And Dr. Taylor, did you want to chime in with something as well?
Yeah, I just wanted to close this up and add that, those that have sort of been working in the policy space are starting to think about what implementation looks like, right? And that's why being able to talk through this in this forum is so important. But groups are also seeking, support from funders to do this work in a more deep way over the next couple of years, since we've had such amazing policy advancements. And so, I don't have more to share on the details on that right now, but definitely be on the lookout for those opportunities, for groups that are going to be seeking funding and looking at this in your states. They could be contacting you to be a part of new research in the field.
Well, thank you all so much. I will thank all the panelists, and thank you all for participating, and good luck in your states getting engaged in the process. And we look forward to see what happens nationally. It's exciting, as Alyson shared. So thank you so much for coming this morning, and enjoy the rest of your conference.